Hello and welcome to today's webinar for mental health professionals, Telehealth for Evidence-Based Treatments, Clinical and Ethical Applications, featuring Dr. Rachel Bussman and Dr. Jamie Furr. My name is Vicki Spielman and I am the Associate Director of Membership and Marketing at ADAA. I would like to now introduce Dr. Rachel Bussman and Dr. Jamie Furr. Dr. Bussman is the Senior Director of the Anxiety Disorders Center and Director of the Selective Mutism Service at the Child Mind Institute. Dr. Furr is a Clinical Assistant Professor and Senior Psychologist in the Mental Health Interventions and Technology Program and the Selective Mutism Program at the Center for Children and Families at Florida International University. She is also the President of the Selective Mutism Association. I will now turn the presentation over to Dr. Furr.
Thank you, Vicki. Okay, so welcome. Go ahead, Rachel.
Thank you so much for having us. We are, of course, very excited to do this webinar and wish that we were doing it with our other presenters as well as it was planned at ADAA, but we're very glad to be here today. We're going to be speaking about telehealth and telehealth for evidence-based treatment, and we will definitely pay specific attention to the current health crisis. We do want to acknowledge our other presenters who really collaborated a lot on this presentation, Mary Alvord, Jill Emanuel, and Nina Schifrin, and we thank them for their participation. So we have a bunch of topics that we're going to discuss today, and this is really just an introduction to our presentation and our learning objectives. So we're going to speak a bit about what telehealth is and discuss the current research base and clinical practice of telehealth for evidence-based treatments. We will describe some adaptations for treatment when conducting evidence-based care via telehealth. And we'll also discuss some ethical considerations and privacy concerns when implementing evidence-based treatment via telehealth. So it goes without saying that this is really a time of uncertainty. I think all of us are managing as best we can during the coronavirus crisis, and we as mental health professionals are really trying to navigate the landscape of telehealth, which some of us have been doing it for a while, some are very new to it, and it's accelerating at a very rapid pace. So we hope to just first acknowledge that this is a really uncertain time for all, and that delving into telehealth really requires some flexibility and a degree of innovation. So we'll start just more broadly about before we delve into this topic more deeply, just what is telehealth? So telehealth refers to the use of telecommunications and virtual technology to deliver healthcare outside traditional healthcare facilities. And so we'll talk more about what this looks like, but it really is quite a complex topic, and really we are talking about a lot of different ways of communicating. So there are definitely advantages to telehealth in general, and we're going to look at all of them, and then we can definitely talk about them. And some of them really apply to telehealth even if we weren't thinking about the current healthcare crisis, and then some of these are very specific, and we'll both talk more broadly and specific. So certainly telehealth has an advantage in that it allows providers to reach people when there are otherwise barriers. And some of those barriers, we'll talk about more fully, but one of them, just speaking quickly, is that let's say you're doing a telehealth session with a family and you're able to record it with the patient's permission. That family member themselves or a spouse or partner or other caregiver could review it later for viewing. And when Jamie speaks about using coaching and when she has videos, if you recorded a coaching session or another session, that could be viewed again by the patient or family. Telehealth of course, allows us to maintain continuity of care when there otherwise would be some sort of a pause or some kind of reason to stop traditional therapy. So some of the things that come to mind would be a patient going to college, or being on vacation, or being away from the place where they normally see you for any extended period of time, camp, illness, and of course now with the current health crisis, many of our patients have been forced to go back to a home state when they were in a different state, let's say for college or school, or there are a lot of different reasons that the continuity could be interrupted. And with telehealth, it allows us to really prevent this pause. Certainly, when we talk about other advantages, we can speak about enhancing parent training and enhancing family involvement. So many of us think about PCIT, or parent-child interaction therapy, as being something that happens in an office with a PCIT room. And you'll find out later for sure that there are a lot of internet-delivered treatments that are quite effective. So really, parent training in some ways can be enhanced. And similarly, if you are working with a child and doing some parent coaching or parent sessions in the home, you actually can do some real-time interventions that you otherwise wouldn't be able to do, because the office provides a contained environment, but it also isn't synonymous with being home. In terms of exposure treatment, there are certainly limitations that we'll talk about later, but some of the things we've learned and we know is that exposures can actually be enhanced or enabled in the home environment. So in treating OCD via telehealth, you can actually see a patient in their kitchen or in their room, or you can see them over an extended period of time, or check back later around exposures or response prevention. Similarly, while social anxiety might not be evoked symptomatically because the child isn't doing a presentation at school, you may be able to do role plays or do exposures that involve the patient and their social anxiety fears. You can also always bring in a third person, and certainly we can speak about just the remote learning environment as being full of social anxiety exposures. And then new client assessment or new patient assessment. I think many of us might think initially, you can't see a new patient. How would you do that without having them in your office? And I think this is also an opportunity to think about flexible interventions and ways that you can evaluate a new patient or evaluate a family in ways that are innovative and still allow, prevent a delay in otherwise accessing treatment. Obviously, with risks come, with challenges, or with benefits come challenges. So obviously, we think a lot about privacy and any kind of interruptions that might come in the way of keeping telehealth going, right? And I think even we see real-time innovations happening now with regard to video conferencing platforms, but certainly we want to think about privacy and any kind of interruptions that would inhibit our ability to do good care. Technology can and does have glitches, and so you always want to be planning for that in advance so that you as a clinician feel more confident, but that your families and your patients feel less anxious about the technology. And there are definitely tips for that I think, and also there are exposures to the uncertainty of technology. Sometimes, and not unsurprisingly, maintaining someone's attention via telehealth has its own unique challenges, right? I think many of us have worked with teenagers or younger or adults where someone is on their phone at the same time, or it's kind of clear that attention isn't fully present. And again, there are ways to navigate that and even use reinforcement for staying on, on track. And I think also being flexible about things like amount of time spent in a session, like do I need 60 minutes versus 45? Would 30 minutes of an intervention be more successful than having this standard 45, especially when it is hard to maintain attention? It certainly is hard to read someone's nonverbal cues or even assess all the aspects of mental status, or just there are definitely things that a video camera or a phone call just cannot capture. And at the same time, we're really trying to do the best we can while knowing that later when we can be back in the office, we want to encourage that if possible. Certainly when we do telehealth and with families in very remote areas, that might not be possible, but these are things to keep in mind. Obviously, risk assessment and crisis management can be much more challenging, and we'll talk later about some cases that really aren't appropriate for telehealth, or cases that you want to be much more mindful about, things like safety planning or having backup ways of communicating with a family. There are definitely limitations on the types of activities that you can do during a session. And again, because of some of these innovative video conferencing platforms, there are really amazing things that I admit I'm learning every day in terms of screen sharing and using a laser pointer and drawing on the screen so that it actually can become kind of something that you learn along the way. But I will say that because there can be limitations on activities, it requires a lot of additional clinician work to find the activities that are going to be possible, or plan ahead in a session in terms of, let's say, maybe you don't have a whiteboard, and I'm not going to draw on my window here, but maybe you've shared a form ahead of time so that a family has it or a patient has it, or you have to be a little bit more flexible around using, let's say, an online whiteboard, or just saying that's not really what we're going to be doing right now. Obviously, and I think Jamie will certainly talk about this later, there are just limitations in terms of when you're using time out room, or when you're working with a younger child who, let's say, is on the go and is going to get up and move away from the camera, or if you're giving a time out and there's certain limits to how to keep things physically contained, but we'll definitely try to address those features as best we can as we go on. And due to, I think this is really important, that due to working from home for really a lot of us, if not all of us, parent involvement may be limited, or we really need to have some flexibility. So for example, I did a parent portion of an evaluation the other day, and I just needed to put out there for the family that we might not be able to do 90 minutes right in a row. Maybe we need to have 45 minutes and another 45 minutes at a different time. Or I would love to speak with both parents, but I maybe need to have the ability to talk to them separately because somebody has to be with the children who are at home. So we have to be flexible. So
Great,
Jamie's going to
Rachel,
take
thank
it from
you.
here.
So great. So let me tell you a little bit about what the research is telling us so far. So luckily, we do have, even before all of this happened with COVID, we were seeing a lot of strong evidence for good patient satisfaction and pretty good provider satisfaction in terms of providing behavioral telehealth services in kind of a variety of forms. We were also seeing that there was good reliability for clinical assessments being provided through telehealth as well. And then there's also kind of a growing body of evidence for the efficacy of providing behavioral telehealth services. And I'm going to speak through a couple of specific trials that we were conducting here at FIU, but there are definitely plenty more. And at the end of the presentation, there's a number of different references and citations that you can access for additional information. So we are finding that behavioral telehealth are comparable to in-clinic, or kind of that face-to-face kind of format for therapy. So which is really kind of the best thing that we can see so far. And then in terms of kind of like app-based applications, large meta-analyses are also finding that these are very effective and practical. So those would be more of like you're pulling up the Calm app for mindfulness, or some CBT-based applications that you can access on your phone. So in terms of like actual video conferencing methods and telehealth methods, there have been a number of studies done within youth and adolescents, and we're finding very good results for amongst kids and adolescents who have OCD, especially Comer et al., which is our group at FIU, and started at Boston University for the younger population, and then Eric Storch and colleagues and Leonard and colleagues also were focusing on kids older and some of the teenagers with OCD. And as Rachel mentioned, you really can kind of get into that home environment where some of those specific kind of obsessions and rituals might be taking place, and apply those exposures right in the home. So it really can be effective in terms of getting into the specific difficulties there. We're also finding very strong results for implementing PCIT, or parent-child interaction therapy, for disruptive behavior disorders for young children. And one of the studies by our group, again, Comer et al., showed that we had a greater number of excellent responders who were in the internet PCIT condition than we did in the in-clinic PCIT condition. And so we're really thinking that's because, again, we're getting straight into the home environment where most of these behaviors are often occurring, rather than in sort of our sterile office, environment where they may be having, we may be seeing the child acting in a much calmer way than they would be if they were in their own home. So we actually think we're kind of getting parents really trained well, because we're doing some live coaching, which I'll show you in a little bit what that looks like with some video. Currently, a trial of PCIT for disruptive behavior disorders and developmental delay was just underway. I think they're just completing some final assessments here at FIU. And so hopefully we'll have some results for that. And then we're also seeing another study by Carpenter et al. Was applying kind of a family-based coping CAT, or for kind of anxiety in middle childhood, and saw high rates of response, meaning like there was increases in anxiety, there were good rates of parent satisfaction, and there was actually pretty good alliance in terms of kind of that the child and therapist alliance, as well as the parent and therapist alliance throughout the course of the treatment. And so we were seeing good effects there. And then there was also, we're just finishing up another trial here at FIU as well, which is implementing a internet-based treatment for young children with anxiety. And so hopefully those results will also be coming out soon. And then the largest trial to date is actually getting kind of up and running finally, and then all of a sudden COVID hits, so we'll have to see what happens. But this is through a PCORI grant, and it's being conducted at the University of Washington in Seattle, Johns Hopkins, Boston Medical Center, and BU, and then here in Miami at FIU and Nicholas Children's, where they're going to be examining kind of face-to-face treatment versus an internet-based CBT version, to see kind of how these things are affecting kind of the pediatric population. So hopefully we're going to continue to have more research, at least within the child population, and I know there's continued research happening in terms of the adult population as well. So not only does the research experience tell us that we have good kind of results so far, but we've also kind of, at least many of us have been doing this now for a while, but also even just in the face of COVID, many people have already kind of jumped on the bandwagon and have been doing this for some time now. And what we're finding is that families are really still telling us that they need support, and that they have interest in doing and using telehealth services to gain that support and to continue working on their mental health needs. So there's also additional funding coming out, and a lot of researchers are trying to determine ways in which they can kind of use this time to determine how best to use these telehealth services to get to the population and best serve their needs. What we're also finding, as many of you probably already know, is that the government and the states really loosened some of the restrictions on HIPAA to make this an easier kind of format to use, so that we can continue to do our jobs and to be able to provide services, so that we're not ethically just kind of dropping patients off when we're not able to kind of find a HIPAA compliant format quickly and easily. So I think many things are kind of turning over into more HIPAA compliant formats, but if you're not able to do that, then if all you have is FaceTime or Skype and you're really trying to ethically provide treatment to your client, the government is not going to kind of cite you for those violations right now, because they really just want people to be able to access their services. So again, many of us are providing telehealth services right now. There's lots of consultation going on about how best to do so. And so I think with appropriate planning and management of the expectations, not only on your side as a clinician, but also on the side of the family, to let them know kind of how to set themselves up, as well as to know, hey, this may not be like that we're going to be making exceptional strides here with the treatment, but maybe we're kind of keep things status quo, or maybe we're going to keep you from kind of having a regression, and hopefully we'll continue to make gains, just like we see research findings that people can still do extremely well through the research, through telehealth methods, that we can provide telehealth services. It's really important, and we're going to talk through this a little bit later in the presentation, that you document kind of the risks and benefits of the telehealth services kind of in your notes, in your documentation, so that you have it kind of in your notes later that you had reason to go into telehealth services. So whether that was because of the COVID-19 crisis, or again, because of X, Y, and Z, you needed to move to that platform. So I'm going to switch back to, nope, I'm going to talk a little bit about what we're going to be going through. And so we're going to talk through some examples of the clinical applications of telehealth, as we were kind of alluding to earlier in the presentation. So we're going to be talking through some examples of individual therapy, of group therapy, because these are things that people are kind of probably most involved in at this time. And then for those of us who do continued work with the parents and parent-based interventions, we're going to talk through some more examples of that type of clinical application. And then also through new evaluations, as we said, these can definitely be done, and that we're finding, again, good reliability on these assessments. And then also, how do you collaborate and get sort of that consultation with other people, and how do you still get that kind of corroboration from other people in either the child's life or the adult's life to kind of support your assessment or your treatment efforts. So I'm going to now turn it over to Rachel to continue our conversation. Rachel?
So in talking about clinical applications, I mean, I think we have lots of examples, but I want to just highlight that it is definitely possible, and we are doing a lot of treatment individually, and it requires a bit of flexibility, right? So in terms of these cases are all examples of cases that are not necessarily myself, but that we're treating over at Child Mind. And for some of them, there needs to be a little bit of a shift, and for some, not much shift. Right. So and I noticed that these patients are all 10 and up, but many of us are doing selective mutism treatment and anxiety treatment with young children, definitely under 6, and that is definitely possible. And I'll talk about that in a second. But for this 10-year-old with generalized anxiety, for those kids who have generalized anxiety, they have a lot of different fears, right? And a lot of different areas you might be targeting, doing exposures after laying the groundwork for psychoeducation and teaching about anxiety and avoidance and all those kinds of things. And so for this particular 10-year-old, we happen to be doing some subway exposures as part of some of her fears and worries, and that's just not possible right now. And it really would, to me, I don't always use a ton of imaginal exposure, but I think there are lots of other things that are raising some of her anxiety right now. So being thoughtful and planful and saying, the subway is not a method of transportation we're really taking right now, and you're managing new demands from school every day, you're managing how to keep yourself both in a balance of getting assignments in on time, but not excessively reassurance seeking about assignments, right? Or worries just about health in general. And so the shift here has really been still engaging this 10-year-old in treatment. She's actually much more familiar with internet delivered interventions than I am, because she's on Zoom a lot during the day, and including the family, because reassurance seeking for this particular child and having parents answer questions is a big piece. So making sure that we're addressing that with either concurrent family involvement or even just having separate check-in times for parents. We also had a patient that was doing some intensive treatment, a teenager working on food exposures related to OCD. And actually she had been in our intensive OCD program, so had really been coming 5 days a week and had stepped down to 2 to 3 times a week. And so one of the worries was immediately, this is going to be way too much for us to be able to effectively manage and provide good care, and at the same time with a little bit of flexibility and some parent involvement to sort of reinforce exposures and make sure that the teenager was set up for success with food available and technology available and some reinforcement. The clinician has been able to do food exposures and do some eating exposures. Obviously, they're not eating together, but they can be eating, she can be eating, the clinician and the teenager can be eating, and it actually allows some, again, as Jamie said, real-time application, because eating in the home for this particular patient is harder actually than eating in the office. This has, again, required, as I think we'll talk about, increased family involvement or shifting the idea of how parents are involved in treatment. Similarly, an OCD patient who has some contamination, and this really actually goes right to the additional benefit to having in-home exposures. So she has sort of a specific specific symptom profile with contamination specific to the home and specific people who've been in the home or have objects in the home. And so in that sense, treatment can go right to the place with a pretty high level of anxiety and exposures being high on the fear ladder. The shift here is making sure not to go all the way up the ladder without appropriately addressing lower level exposures. And I think the other really key piece here is that while telehealth can absolutely involve exposure, response prevention, parent involvement, it doesn't take the place for the work that needs to happen in between sessions. So one of the barriers here is just patient follow through on exposures and homework. And so one option from the family was a suggestion that maybe the patient could be seen more frequently, which I think is a great option, and also a conversation with the clinician around in between session exposure and family getting involved in helping to keep those going, because it really, we want it to generalize to times for sure when the clinician's not present. And then just highlighting a few older patients, I'm sure, well, older in my mind, I guess not older on the lifespan, but that we definitely see some students and a vulnerable population right now is a college age and graduate school population where there is a tremendous amount of change happening for these young adults, where school has now moved to an online platform. And so certainly a 21-year-old who goes to college and has social anxiety and also ADHD, who's now at home when he's been away from home and is also trying to navigate keeping a schedule when a lot of academic tasks have shifted to a completely sort of manage your own time. A lot of coursework is being recorded or asynchronous. And so that has definitely, in some ways for this particular case, maybe the anxiety clinician who's been doing social exposures or social anxiety exposures needs to shift to do some executive functioning work, or really take a step back and say, let's make sure we're helping you set yourself up for success so that you even can access your education, and before you can participate in class or participate in assignments, we need to make sure that we're taking into account some of these shifts and how your learning style might differ. So that's been the shift there. And I'll just say finally, this 23-year-old, I think is just a highlight that we can absolutely work with patients who have comorbidities, and we also want to sort of stay on top of things that were sub-threshold depression or resolved depression. We want to stay on top of things like behavioral activation and figuring out and collaborating with a patient a way, if they live in an apartment or live in a place where they can't go for a run like they did at school or in their old environment, how to still help them stay behaviorally activated and address the current symptom presentation, and not the least of which also some of these young adults are moving back into a home with their parents when they hadn't been living there, which just opens up a lot of challenges, but also opportunity to do some family work. So I think this really just highlights that all of this good treatment needs to be kind of a moving target in terms of assessment, right? Pivoting where we need to, and consulting with other providers and agencies, which might mean talking to an outside psychiatrist. It definitely means speaking to a school. It means involving parents more or less in some cases, right? Depending on the age of the patient. So it really requires a lot of flexibility. And then similarly, I think on the next slide, I know that Jamie's going to talk about this more, but just a few of the things that are happening, again, in lots of places, but definitely at Childmind, we see a lot of children with selective mutism. Many of the children are quite young, and we run a group every week, which is a live group in person, and it requires a lot of moving targets. We have a group leader, we have multiple program assistants and graduate students who are part of that group. So first, we put that on hold while we regrouped and said, how do we make this feasible, especially for a population, I think specifically selective mutism, and I'm sure other populations are the same, feeling very vulnerable and disconnected from the places that are where we want to see progress. And so what we did for our shift, we're now about to run our second group 2 weeks in a row with actually interestingly increased attendance, which I think speaks to the ability to reduce one barrier. So for some of us, we have out-of-state patients now attending where of course they can't attend our group on a weekly basis. So managing expectations, one of the ways we did that was once we figured out what we wanted to do, use Zoom, screen share, we wanted to manage the expectations of the parents, right? So meaning your child might have been really successful with us in person, and this is a new platform, so we need to be both supportive and a little gentle on the expectations. So our first expectation was just attend group. It wasn't even a whole lot of goal setting. We also sent families do's and don'ts in terms of here are some things you parents can do to help, and here are some things to avoid during the session. We did what we called tech checks, which were actually tech checks, but also were our opportunity to make sure the child was verbal with us in this new place, so that we were just reducing the things that we needed to do live in the moment. We've been using a lot of screen sharing, and you can screen share things like Nick Jr. or Go Noodle, which makes it really engaging and fun. And then Zoom in particular, but I think other platforms have these breakout rooms where you can actually have a subset of your group, which I actually think has been really exciting and kind of invigorating. We also have CBT groups for anxiety disorders. We have a social anxiety group program that's been running pretty steadily every 10 weeks, and the next version is starting next week. And again, managing expectations of clinicians, wondering, is this going to even happen? And we actually are going to be running 2 groups starting next week. Of course, needing flexibility. So the group runs for 10 weeks, we're going to run it for 5 because we're not going to be going bowling with kids, and we're not going to go out to Grand Central Station and ask where's Grand Central Station. So there's both, we can do it, and there are things we won't yet be able to do. And then just another piece is that we at Childmind have been trained in the unified protocol and plan to run some groups later in the fall, and we haven't put that on hold in terms of we're still planning to plan those groups and plan for them live, with the idea that we can certainly plan for those in an online format, again, just being really mindful of the things that are going to go well and remembering that some of the things you think might not work could work if we try them out and test them out. And I'm going to turn this back over to Jamie.
Great, thank you. Yeah, so I think all to say that, I think really kind of keeping an open mind will let you think through what you're already doing and how you can kind of transition that to to this online format. And so talking through some of the parent-based interventions, I'm going to show you some clips on parent-child interaction therapy for disruptive behavior disorders, but it's very similar to a lot of the work that we're also doing here at FIU with kids with selective mutism, at least in the beginning kind of phases. And then, as I had mentioned earlier, we are kind of wrapping up kind of an internet-based intervention for young kids with child anxiety. And a lot of these formats are kind of based in the PCIT treatment because it's really developed for young kids and is designed to kind of coach parents through a bug in the ear, which I'm going to show you, and then kind of adapts and kind of has the parent kind of coaching the child into exposure. There are Cool Little Kids for Child Anxiety, which is really a full parent-based intervention for young kids with anxiety. And because it's just parents, we can do that one very easily over the internet, and they also have a web-based platform that you can use as well. And then, as we were talking about before, there's going to be kind of a fair amount of family therapy component, or you may end up having a bit more parent involvement in more child-focused treatment. And so what we mean by that is, as one of the studies showed before, even just implementing coping cat, which may tend to, a lot of us do that in a more individual basis, but you really can make that more of a family component. And the trial that was conducted was using that type of format where it was really the parent and the child being together. So you may have to be, again, we're really talking about flexibility here. So thinking through how can you be flexible if the parent is working and you really have the time with the child at that, for a session, really kind of taking that time with the child, and maybe you plan a time to check in with the parent later on what those skills might be. Or what is really nice is kind of if you have the child really teaching the parent, what did I learn in today's session, just like you would if they were coming into your office. So you really might, depending upon the age of the child, need more or less family involvement. So what we're going to do is move on to, if I can get my screen to progress. There we go. So I wanted to show you a little bit of what internet delivered PCIT looks like. So as you can see kind of in the top picture, this is what the in-clinic version would look like. And so you can see that it's extremely conducive to transferring it to an online version because you're already behind a one-way mirror. You're already coaching through a bug in the ear where the parent is using a device. Oftentimes we're using just a regular Bluetooth and having that connected to the computer. And so you really can see that this is extremely beneficial because we're really just taking that one-way mirror and turning it into our computer or our laptop or iPad. Any of those devices will work just fine. And so it's really kind of walking them through and setting them up and making sure, as Rachel was mentioning, some of those tech checks and making sure that they know exactly where you want the computer to be. And you should really do this for any of those sessions, regardless of who's participating, and making sure that all of these things are kind of in the best for their sessions. So if, again, you're treating a kid anxiety and you're going to be coaching a parent through an exposure in the bathroom, then make sure that computer is ready to go in the bathroom, or they have moved their iPads and things are ready to go in the bathroom. So this is what it looks like. I'll show you a little bit of video so you can see that the coach is on the screen at the same time as the parent is there with the child. And this is actually a setup where the timeout chair is right there in the view while they're playing, so that the therapist can make sure that they can see that timeout chair. Similarly, this is another type of format where you can see where the parents are playing. So you can see that the camera is kind of a little bit set back so that, again, you have full of the parent and the child playing. This one was a little trickier because you can see behind them that there was a whole set of toys. So for the child, it was a little bit of a tough situation because although this was the only spot that the family felt like they could really practice their time playing, the kid was often distracted by the toys behind them. So we typically try to recommend that families go into a closed space. If you can go into a room that may have less distractions, and close the door, so that, again, really kind of thinking of it as a therapy time. so that they're really making it their space, and the child is more focused on what you're doing. And again, that would really fit for any type of session, not just PCIT. So I'm going to show you two short clips on, again, these are just PCIT clips. And again, I'm showing you these because this is what we often use for PCIT for disruptive behavior disorders. We use it at the base of our work with selective mutism, and as well as young child anxiety work, at least here at FIU. So hopefully this will play.
Coach CDI for a few minutes, so remember to use all your CDI skills. I see you're settling in really nicely.
The green one. This is going to be such a tall tower.
Great behavior description. I love how far on for play.
Oh, Castle for Rapunzel.
Great reflection.
We like Rapunzel too.
Great reflection. Really nice job reflecting that back.
Oh, okay. So she was your friend anymore. Okay.
You're doing a beautiful job following her lead.
You can see that the parent has a Bluetooth microphone, so that again you really can pick it up. And you can see down at the bottom that there's a floor microphone.
That's a good rule. I like that rule.
But that's not really necessary.
I get to be a veteran too.
So she's really doing a good job building that tower.
I love the tower you're making.
Great label, great.
That's funny that we found it with our Legos and our blocks.
Really nice enthusiasm. You can tell she's in this play with you. And you're really letting her know you're listening and you approve of all the great things she's saying.
I love that you stay so calm. Oh, it doesn't work.
Great little phrase. That was a really nice little phrase.
Oh, it needs a battery. You're so smart that it needs a
great
battery.
reflection. A great little phrase.
Yeah, it doesn't work.
So you can see that the camera is positioned far enough back so that you can see both players. And then again, any type of Bluetooth device can connect straight to the computer. Again, we often have families who don't have the Bluetooth device and they have their phone set next to them, and sometimes we're calling their phone directly and they have their headpiece attached to their phone, and that is picking up the sound, and typically that's enough. Again, as I mentioned, there is a floor microphone that parents can purchase if you feel like they need to and you really can't hear things. But again, we've had fairly good success with even just having the phone next to them. This is a PDI version, so you can what it looks like to put a child into timeout when they're at home. Hopefully it will play.
Oh, you're doing really nice. You're coloring. Big orange. You can color along with her. Really nice. Orange apple. Coloring together. Putting the orange down. And you're choosing the purple. I like how many colors. Beautiful label, great. Okay, Jamie, is there anything you have to use our PDI skills? Find something you'd like for her to answer. Raise your hand. 1, 2, 3, 4. Children, if you don't need a block, then you'll have to sit on the chair. Sure, 1, 2, 3, 4, 5. Tell her you didn't do. You didn't do what I told you to do, so you have to go on the chair. Nice job staying calm. We're bringing her to the chair. Tell her you can get a beautiful job with the chair explanation. I'm going to go back to the side. Beautiful job. Calm. While you're on the chair, do that in high top by the side. So, know in the 3 minutes. Nice job. Go ahead and boys are on the play.
So the nice thing about doing this type of treatment within the home specifically is that you really are helping kind of, again, parents in the specific environment that they might have difficulty implementing a timeout. And so again, with a typically difficult population, again, she's sitting nice and quietly, but oftentimes, you know, we've seen kids standing on the chairs and doing similar things that they might do in your office if they're having difficulty. And so it's nice because you can kind of implement, you can be supportive of the parent in the home where they may not typically have that type of support while they're going through their practice in the home environment. And so, you know, similarly, you can coach a parent through, again, kind of doing an exposure and implementing other types of treatment as well. So just wanted to show you kind of what some of those setups can look like. And again, I think that's probably why at least our site got some pretty good results with the PCIT study. I wanted to show you another clip on, this was a part of our early work with young kids with OCD online. And this is how we sort of made the work happen for creating their own kind of worry monster or the bully that you used when you're implementing treatment for OCD with kids. So we created, we used a lot of Google Docs and then shared the screen and passed the presenter function back and forth and allowed them to create their own monster, which then could live, again, in a Google Doc that didn't have any identifying information on it, so that they really kind of had control over making this thing and being able to share it back and forth. You didn't have to do it this way. You can always use just again, a paper and, you know, crayon, just like you would in your office, and take pictures of it and share it back and forth. But we thought this might be a little bit more interactive for them.
Where you get to create your very own worry monster. So you can like drag and drop so that you can create a monster. So I'll let you do this.
So we used a Google Doc and just found some images of different type of monster features, and then the child could choose whatever they wanted to make their own monster. And this is with kids ages 4 to 8. So clearly you have parent involvement, but the kid was the one who got to move this around and be involved.
Yeah, he's looking good. What do you look like?
So clearly you need some parent support, but this really gets them a little bit more engaged in the process. So they liked that a lot. We had some other things. So this is about creating a fear ladder and how you can set this up as well for them. So again, we used a lot of Google Docs for this work. This was also in our early OCD study, but we also used a similar feature for our early anxiety work. And so again, you can use a Google Doc to create whatever type of fear ladder you would like, or step ladder, and then we just made little boxes that they could add in what they wanted, and again, you can trade back and forth, and you can see some of the types of fears that they were entering in. And again, this lived on the Google Doc, so then you could go in and change it.
Last week we talked about how hard certain things were and maybe how a little bit easier certain things were. Yeah, a little bit. So what we'll do is we're going to build up from the easiest thing that the worry monster asks you to do, and then we'll go all the way to the hardest things the worry monster asks you to do that's hard to boss back. That makes sense? So maybe we'll start with something we did last week. So last week, I think we asked you about what if you had to be alone in a room without mom or dad? And you can drag it around to where you think it might be. So, for example, Ollie, eating alone in a room. How about with the door open? Can you see what I'm typing? Okay.
So you could type those things in and then pass the presenter function and then let them move that around to a different spot to make sure they can put it where they would like for it to be. Okay, I'm going to pass it back to Rachel to talk about new client evaluations.
And I just want to say I love the interactive nature, and I love the videos and the clips, because I think it allows everyone to really see how it's done, and that you can really customize it to a child's particular interests or particular preferences, because you can always find images of things they like or reward sheets that they like. So I think it really leaves a lot of creativity. So just for clinical applications for new evaluations, I mean, I think when you're thinking about a new evaluation, you're doing all the things that you would normally do, right? So you're getting all the paperwork, and you're getting, your intake or your evaluation has come to you through a particular channel, and that probably hasn't changed. One of the things you want to do before you even start is assess for appropriateness at the front end. So meaning appropriateness for telehealth evaluation at the front end. And so some of that involves just checking licensure related issues. And we're going to talk a little bit later or in a couple of slides about interjurisdictional practice, knowing that there's some loosening of guidelines and some not. So we had an evaluation inquiry to us the other day, and it came from a particular state that first I was wondering, this doesn't seem like this would be a good intensive treatment. This just seems like standard CBT and a good evaluation, but not for someone who probably isn't going to be able to follow the patient later, and really should be referred to a mental health provider in that state, because this particular state doesn't have any reciprocity loosening with New York. And so it already from the front end seems like not a good case to take, but we were able to give some referrals right in that home state. And just assessing for appropriateness, we might talk a little bit later, but just if you're getting, especially an evaluation that's from a step down from a higher level of care, you really want to be very thoughtful about if it's time to step down from that level of care, and if it's going to be appropriate to do a telehealth evaluation, knowing that there are some barriers to your risk assessment, for example. Setting expectations with the family, I think, is very important. So I know for us, families are used to seeing us for a certain amount of time for a parent portion, and a child portion looks a certain way, whether it's a live observation or a child interview. And I just find that it's always helpful to set expectations and answer questions at the front end before you even get started, so that people don't have misaligned expectations, right? So saying something like, usually I spend 60 minutes with a child, your child's 6. So that might look a little different via the telehealth appointment. And that way, do you have any questions? Are there some concerns that you might have about this? Or even not even saying, do you have concerns? What concerns do you have, so we can address them? You still can get rating scales. I love to get video sample, and you can still get collateral information. Again, being flexible with the fact that none of us have scanners. Many of us don't have scanners in our homes, and a lot of families don't. So taking a picture of, signing a release of information, or just having already laying out some of the barriers, like, don't worry so much about this paperwork. If you can't navigate our patient portal, we can send this to you in a way that's more feasible and doesn't cause much stress. It's going to really help people feel much more comfortable. And then, of course, any modification for special populations, which could be like diagnostically special, or age, or developmental level, or just Maybe there's a certain aspects of the family constellation where you just need to be more mindful of time and resources. So all of those things I think are really important when we think about that. In terms of consultation with others, I think that it is both really important and requires, again, flexibility, right? So I have, and we continue to have a lot of collaboration with teachers and professors. We participate in 504 and IEP meetings. That being said, if you're working with a family already, using the ability to have a conversation with a family and manage their expectations about some of the things that are very important to them, as schools are also navigating serving other students, figuring out how their telehealth or how their video conferencing abilities are working. So I did actually have a pretty lengthy IEP meeting the other day, and it actually ended up being pretty successful, but we all had to be a little patient as some folks couldn't get online and some folks needed to be in a different location, and just, I think, helping your families feel more comfortable to expect some of these glitches actually helps people feel a lot calmer. I already sort of talked about that step down situation, but just a little bit in more depth. This particular patient was going to come to our San Mateo office, actually, on our West Coast office, and was stepping down from partial. And really, we actually took a little bit of extra time to really have a conversation with the family, have a conversation, of course, with permission with the partial program to really determine if a step down was appropriate at this time. It actually ends up that it's going to be in the next week or so, but whenever you're going from a higher level to a lower level of care, or you have risk factors, you really want to be quite mindful and thoughtful, I think, setting expectations ahead of time so that you're not feeling constrained by something later. Again, consulting with psychiatrists. We have the luxury of having a bunch of psychiatrists that we work with at Childmind, and also collaborating with other outside providers, with the caveat that everybody is new to this. So like Jamie is already an expert in internet delivered care, and not everybody is, and not every psychiatrist is. So some private practitioners who may have different experience with telehealth might need some patience or your flexibility in saying, hey, if you can't get on a video call, that thing called a phone also works really well, and we can use that too, because I think there is naturally different levels of comfort in terms of how to communicate. And then just if the patient's getting other support. But I also would say, I don't think Jamie and I even talked about this, but just the idea of collaboration and consultation within your team, supervision meetings, consulting with others. I recently had a clinician on my team who's new to being an attending and is quite skilled. She was feeling very really not very confident about her session that she had, but during supervision got a ton of labeled praise because we actually thought she did a great job checking the technology, meeting with the parents, managing expectations, but her expectations for herself of what she would do in the room needed to really be shifted. And I think, again, having support and peer supervision and just supervisor supervision really helps people feel not alone. I'm not going to go through all the different platforms because I think people can read that, and there are some references at the end with some really great resources. I know Mary Alvord is super skilled in this area and has done a lot of webinars. Just to say, there are a lot of different platforms. There are a lot of HIPAA secure platforms. And also, as Jamie was saying, there is some loosening of restrictions in terms of what we can do to meet the needs of our patient. That being said, we still want to explain to patients how to use a platform, what the limits are, and just obtain appropriate informed consent. It's not the Wild West. We're just really wanting to be flexible and offer different formats. Similarly, certainly we want families to complete informed consent. For some families, some practices have very formal informed consent processes, and some have more informal. And I think the guiding principle should really be both Making sure to be thoughtful and explain things, explain the limitations, explain the usage, and at the same time not let barriers go up, right? So if someone's saying, you know, I can't download this particular form, saying, let's walk through it. Let's walk through it on the phone. Send me this via email in terms of permission. So we want to be both thoughtful, planful, and flexible.
Great.
Jamie, this is, I think, just this last slide.
Yes,
So just in terms of backup plans, you always want to have a backup plan, and you might not think to do this. We might be really good at doing this in emergency situations, but we just want to also have backup information for definitely new evaluations. And even when we're starting our telehealth relationships with families we know really well. So if Jamie's my patient and I've known her forever, I can still say, Jamie, so I know you're home, right? That's still 123 Main Street in you know, Pleasantville, right? And just the number that I'm calling you, that I have in this chart, that's the right number, right? No one's gonna say, why are you asking me this? We're gonna say, we're doing this just to make sure if we get disconnected, I wanna make sure I know where you are. Obviously, when you're seeing a new family, you definitely want to get this information. And of course, for emergency, you want to know where the nearest emergency room is. You want to make sure a family knows how to access emergency intervention if they need it. And those are just things you always want to do and want to make sure you have planned out as you're doing telehealth.
Great, yeah, and sometimes you can even get a backup. So like if it's a spouse or another parent or somebody, if you have like a secondary phone number in case that first, I mean, we've all been in this, right? Where your phone dies, your computer dies, and all of a sudden you're off. So having sometimes that backup number can also be really useful too, just in case. We've definitely had that happen in a number of our trials. So Rachel mentioned kind of the interjurisdictional practice and kind of making sure that before you get going with a particular client, especially if it's coming from, you know, a referral from another state, that you are really with the Board of Examiners and checking with your state as well as the state in question about either temporary or whether they have relaxed the restrictions in terms of practice for telehealth, because again, right, there is some reciprocity happening, and again, there is some loosening, but it, not for everything. And so we've listed some websites here. Again, there's a good website that sort of state by state reciprocity in the realm of kind of of COVID. So you can kind of check that. That's the ASPPB.net website. And so you also want to really think about not only whether there's reciprocity, but also kind of understand what are the, you know, the kind of the protective service laws, as well as kind of the duties to warn in those states, because sometimes there may be different from your own state to those states that you're practicing within. We had some colleagues where they were kind of looking at kind of New York to New Jersey licensure process, and they were explaining that that has been a very easy turnaround for them, very quick. So we wanted to provide that link as well. Yeah. And then in Connecticut, there was also kind of an immediate reciprocity for that. So just to walk through in terms of what the ethical telehealth guidelines are created by APA, we want to go through this briefly with you so that you kind of have a sense of what, again, right, I think if you kind of have these in your mind as you're kind of providing your treatment, and that these are the things that you're doing to make sure that you're kind of in compliance here. I think this is really what is important to make sure that you're doing, even if you can't provide, you know, the Zoom, you know, a HIPAA compliant platform, and you don't have all of the forms, and you're really just trying to make sure that your patients are taken care of. I think these things are things to be keeping in mind. So again, you really want to try to just keep your competency up, right? So thinking about continuing to do trainings on technology. There are so many different trainings happening within APA, ADAA, Division 53, Division 12, lots of different resources for continuing to receive training through telehealth methods if you're still learning and kind of getting yourself up and running. And even somebody who's done a lot of service myself, I'm still trying to go on and you know, take webinars and things so that I can keep learning myself, so that you're kind of understanding the impact of that. So continuing your training is one. And then again, kind of as we talked about before, kind of really ensuring that you're kind of keeping those ethical and professional standards in mind, and throughout the course of the treatment. So I think it's really, as long as you're kind of ethically providing the treatment that you know is best, then again, I think you're on the right track. And again, as Rachel mentioned, really thinking about obtaining informed consent. Again, even if it is by an email that they say, I approve that for us to do video conferencing treatment through the platform, and you have that on record. If that is the only way that you can get it, then get it that way, so that again, you have some type of documentation that they approved of you using this type of platform for services. And again, many types of people are creating these, and I know through APA they have provided templates for that. And again, I provided a website at the end that has that resource. And again, really trying, as you're doing these types of services, really trying to maintain and protect the confidentiality. Again, using email, using FaceTime. Again, those things are not private, and we've been hearing a lot about Zoom bombing, but really doing the best that you possibly can, given all of these different scenarios, to maintain the confidentiality and the privacy of your clients. Again, still kind of thinking about protecting their PHI while you're still implementing these things. I think as long as that, again, is at the forefront of your mind, you're doing the best you can. Again, ensuring that security measures are in place to protect them, again, from unintended disclosure, as we mentioned before. And then again, kind of disposing of data and information just as you would if you were kind of in person. And then again, as Rachel mentioned, kind of thinking about some of those unique issues that might arise through the technology, and kind of test those things out in advance. So hopefully you're not hitting that right when you get started. And then again, thinking through the different laws that are relevant to you and across different states and even international borders if you're implementing services that way. So we're going to talk through a couple of dilemmas and what would you do in those cases. And I think looking at the time, maybe you want to pick one or two, and then these are things that maybe
that's great. And I actually already talked a bit about the referral from the 14-year-old with step down, and I just think that to me the take-home message is that I don't think it automatically means you say I can't take this case, but I think in cases where, or situations where there's harm, there's been a higher level of care, we want to really, to me, it's always better to get more information and request more on the front end to manage expectations rather than take something on and then backtrack. So that's really what we did in this particular piece, was just say, hold on, the patient doesn't need to be discharged from partial yet. Let's have a conversation or two or three to make a really solid plan that's going to ultimately be a better transition.
Yeah, exactly. I look like the angry teenager slamming the laptop closed, ending the session. Again, this is where having that backup information and having a phone number, maybe having the parent know that the session is taking place, so that you can have somebody to reach out to in case that happens, and having a sort of a policy in place ahead of time about you know, what the expectations are of the treatment, and also what might happen if that does happen, and sort of expecting that to happen probably once or twice throughout your treatment, you know, not only with a teenager but maybe with others as well. So yeah, that definitely can happen. Did you want to talk about any other ones, Rachel?
Yeah, I mean, I think just during the course of a session, your patient expresses thoughts about hurting themselves. I think we all are pretty good risk assessors. And I think, again, knowing that you've hopefully already talked about limits of confidentiality with your patient, so it's not a surprise, that a parent or a caregiver knows that a session's happening. These are all things that really are the same regardless of where you're seeing the patient. And really any change in mental status, you would really want to get some more information. I can think of something that happened recently with a patient who we thought was maybe having some manic symptoms, and really just having a conversation with a psychiatrist, getting some more information from the teenager, getting a rating scale when possible, and then also taking it in the context for when I'm thinking about mania in particular. I'm just thinking that a lot of people haven't been sleeping so well, so with the current situation. So really, in this particular case, it was about the clinician reaching out to the supervisor, weighing like what the particular situational factors were, talking this to the psychiatrist, and finding out that there had been a switch in antidepressant was really, really helpful to get the full picture. So I think these are, I'm sure people have more, but we have a lot of resources to share, and hopefully those will be helpful.
So we wanted to provide a sample of resources regarding kind of interjurisdictional limits, as well as kind of using telehealth. So there's a number of resources here. 60 is a kind of a book that you can, or a manual that you can use that discusses kind of use technology-based services and tools. And then SciPact is that the ASBPB Board of Directors has been working on very hard and have a lot of resources to work through interstate kind of reciprocity. And so they've gained, I think it's like 15 or 16 states now. And so I think they're continuing to work on more where there's reciprocity in those states, so that you can kind of use your license across those different states. So you can access that website there. And then, as I mentioned before, APA has a whole list of resources that psychologists and other practitioners can use for telehealth. So I wanted to list that link there because it gives you different consents, goes through different webinars, things that you can kind of adapt to your own practice, that way you don't have to reinvent the wheel and come up with it all on your own, which right now you probably don't have the time to do so. And then these are a sample of the references from some of the more of the research-based articles and some of the other like practice parameters that others have been working on. A lot of the work that Kathleen Myers has been doing on telemedicine and those guidelines as well. And so we just want to thank you so much for all of your attention. And here's our contact information if you have any further questions. So thank you so much for your time.
Thank you so much for having us.
Thank you very much. For those of you who purchased CME credit for this webinar, you should have received an evaluation link in your registration confirmation email. You must complete the webinar survey and post-test questions to receive a certificate. If you have questions, please email us at webinars@adaa.org, or if you did not receive the link, email us at webinars@adaa.org. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, and much more. We would also like to invite you to check out more ADAA on-demand webinars by visiting www.adaa.org. On behalf of ADAA and our presenters, we thank you for joining us today.
Thank you.